right. Well, welcome everyone. We'll go ahead and get going with our educational presentation today. And I'm excited that we get to spend the next hour with one another at this presentation on the role of hospice and medical aid in dying, which of course is a very topical and important topic for New Mexico right now, as so many hospices are making decisions on how it is that they'll be supporting patients and with this new option that's available. My name is Matt Whitaker, and I'm the National Director of Integrated Programs at Compassionate Choices. And today I get to play the part of moderator and a housekeeper. So by way of housekeeping, before I introduce our presenters, I just want to let folks know that today's webinar is being recorded. So just want to make sure you're aware of that. We'll make sure that's available in perpetuity after today for those folks who are unable to join, or if the information that you hear strikes a chord, you want to make sure that you're sharing that with other folks. It will be available to people. Our presenters today, as you'll get to know better throughout the presentation, are Lily Hopkins, who is on the End of Life Options New Mexico. She's a board hospice advisor there, a hospice clinician with a great deal of experience. We're so excited to have her share her perspective today on the webinar, as well as Dr. David Grube, who is Compassionate Choices National Medical Director, and as you'll hear from him, has a long history with hospice, and particularly in this space of realizing how it is that hospice and medical aid in dying coexist, and how it is the practice kind of integrates itself into hospice. Just quickly to go over some of the learning objectives for today. Again, our goal is that the people who are on this presentation understand the requirements of this new New Mexico Elizabeth Whitefield End of Life Options Act, that you're able to explore end of life options in hospice and palliative care with engaged neutrality, as you'll come to learn what that term means in regard to medical aid in dying. You understand a little bit of some case histories regarding how it is that medical aid in dying and hospice interact, and that you're able to discuss some of the medical ethical issues that we'll get in later today. Something to note is everyone who attends today will send out a certificate of participation to you so that you have that for your continuing education records. Today is accredited for 1 hour of continuing medical education. And for those of you who pursue continuing ed in other disciplines, we'll send you again that participation certificate so that you have that credit for 1 hour of education that you can apply towards your CEUs or whatever it may be. If you are seeking CME credit, we send out a specific certificate for that. So if you'll send a message in the chat with your name, we'll make sure that if you're a physician, that we particularly send the CME piece to you. Something else to note is that we, on our last presentation that was on September 22nd, we've gotten some emails from folks saying that they had trouble finding that certificate. I think it ended up in some spam folders. So I want to give you a heads up that sometimes it makes its way there because it's coming from a new email. And we're going to actually, as we send out certificates from today, resend those certificates from September so that they're both at the top of your inbox. We want to make sure that you have those and can get credit for this. So just a heads up, if you're having trouble finding those pieces, take a look in your spam folder. And again, we'll resend those things so that they'll be at the top of it. I know if you're like me, my spam deletes after a month. And so we don't want anybody to lose those certificates. So again, we'll be sending those forward so that you have those handy. With that, I'm going to sit back and be monitoring our Q&A box. So if you have a question throughout the presentation today, we're going to do questions at the end for the sake of kind of continuity for the recording. If you have a question, you can type that either in the chat or in the Q&A box. We'll be monitoring that throughout. At the end, I'll be asking those questions to the panelists, compiling those if there's some that kind of follow a trend, trying to make sure that we take that into account as well. So with that, with all the housekeeping out of the way, I'm going to go ahead and turn things over to Dr. David Grube, National Medical Director at Compassionate Choices, to open things up, and then he'll pass it on to Libby. So thank you again for being here, and take it away, Dr. Grube.
Well, good afternoon in New Mexico. I'm in Oregon, and so it's morning here. But I'm always happy to come to your state either virtually or in person, and appreciate your listening to the program this morning. We could go to the next slide. As Matt mentioned, I'm the National Medical Director for Compassion and Choices, but before that's since I retired from the clinical work. In my work as a family physician in a small town in Oregon for over 35 years, I really appreciated stories. That's what every single day amazed me, were the incredible stories that I would hear. And Atul Gawande, in his extraordinarily wonderful book, Being Mortal, says that life is meaningful because it is a story. And in stories, endings matter. And that's what we're talking about today, are endings that are determined on some occasions by the individual who is suffering a terminal illness. One of the take-homes that we have to start out with is the fact that in America, in the United States, it's become incredibly complicated to die. Individuals don't just have a heart attack and die anymore. There are many, many wonderful medical technologies, all the way from renal dialysis to incredible chemotherapy to surgical procedures. But it's turned the death experience into a medical experience. And it makes it difficult a lot of times for us to help our patients to understand what their values and wishes are. And again, Atul Gawande comments on this in that book. So with that, what also comes along with this prolonged dying process on occasion is intolerable terminal suffering, which is ultimately the enemy, since we're all going to die. Intolerable terminal suffering is what the Elizabeth Whitefield Act addresses. Now, these are end-of-life options that we know from our hospice work. The default in American medicine, of course, is to pursue all life-sustaining and then occasionally prolonging treatments. But individuals do have the right to refuse treatment or discontinue treatment at any time. We're here today really to talk about this fourth bullet point, hospice and palliative care. And as Matt mentioned, I've worked intimately with hospice and hospice programs since 1980. And in Oregon, there's been an evolution of how hospice interfaces with the last three options on this list: voluntary stopping eating and drinking, which we'll abbreviate for today's discussion to VSED. Palliative sedation used to be called terminal sedation, also called continuous deep sedation, and medical aid in dying. So we want to address some of the myths that are out there. And I've listed these five. There are others, but medical aid, a request for medical aid in dying does not mean that we as a palliative care or hospice provider have failed. This is really important to understand. We are doing as best that we can, and yet sometimes in some certain situations, what we can provide is not, either may not respect the wishes of the person or does not comfort them in a way that assuages their intolerable terminal suffering. It is not true that medical aid in dying is simple and easy to access. Now, we've had this option in Oregon for almost a quarter of a century. It's new to New Mexico. Your New Mexico law, if I may say, is much more accessible than our Oregon law has been and is. So that's a good thing for your patients, but it still and yet it is not necessarily easy to access. And it's, of course, as you know, as hospice providers, that it's not true that hospices will not support choice. With some exceptions, particularly in faith-based hospices, they may not support a patient's choice. Medical aid in dying is not suicide, and we'll talk about that briefly a bit later. But I think it's really, really important as we work, especially in end-of-life care, to use language that is kind, that is not hurtful or harmful, does not cause fear or anxiety. And therefore, it's very important to distinguish medical aid in dying from suicide. And I have heard, unfortunately, some palliative care physicians say that they can take care of all terminal suffering. I think that's a bit I don't believe that that's true, and we can talk about specific cases as we go through the next hour. Next slide, please. And again, as I said just a minute ago, we want to, when we're responding to a request for medical aid in dying from a suffering patient, we want to be non-judgmental, even if it's not something that we personally support in our own personal beliefs. But it's very important to be kind, to listen, to attend, and to use appropriate language, and to be a professional. And what does it mean to be a professional? To be a professional, it means to put the patient first and put our own personal beliefs on the back burner. Next slide, please. Now, New Mexico is the newest of the states that authorize aid in dying. And you can see these states here. Oregon was the first in 1997, but then subsequently Washington, California, Colorado, Hawaii, Maine, Vermont, New Jersey, and the District of Columbia all have medical aid in dying laws now. And Montana does not have a law, but their Supreme Court has said that it is not illegal. And so it's considered a state where aid in dying is allowed. And in fact, that happens. Next slide, please. I'm going to turn it over now to Ms. Hopkins, who's going to talk specifically about the Elizabeth Whitefield Act. And then I'll be back in a little bit to go through some of the clinical parameters. Ms. Hopkins?
Thank you very much, Dr. Grube. We can move on to the next slide. And if you are not aware, our End of Life Options Act here in New Mexico is named after Judge Elizabeth Whitefield. And our Medical Aid in Dying Act provides, by definition, medical aid in dying is the practice wherein an authorized healthcare provider prescribes meds to a qualified individual who may self-administer the medication to bring about a peaceful death. So we're going to talk about the definitions of these terms as we go along to the following slides. And you're probably aware that our law did go into effect on June 18th. So we are at very different levels in different parts of the state and in different hospices with where folks are in the process and in provision and participation. So in terms of definition, the eligibility requirements for our End of Life Options Act here in New Mexico. An adult, 18 years of age, you must be a resident, terminally ill, a prognosis of 6 months, decisionally capable, able to make those informed decisions and able to self-administer medications. So who is a qualified individual? Well, we've kind of identified 18 years and older and a New Mexico resident. Terminal illness does have a definition. It is an incurable, non-reversible illness, which in accordance with reasonable medical judgment will result in a prognosis of 6 months or less. Well, that's familiar to you. That's also the CMS definition for hospice. The person must have capacity to understand and to appreciate the disease and the healthcare options that are available to them, and the pros and cons and the risks and benefits, of which there are many. But not only that, the person must be able to clearly communicate their wishes and their choice to participate to their provider and to others. Self-administering made medications must be an affirmative, conscious, voluntary action to ingest the medications. And by the way, injection and IV administration are not, they are not allowed here. Voluntary, what does that mean? I mean, you know, in general what the term voluntary means, but in this context, the person makes a request not under pressure, not under any duress, not under any influence of others. So we can go to the next slide. And who is authorized as a healthcare provider to participate in this? Any of the following, and we are very lucky in our state because we include PAs and advanced practice nurses, nurse practitioners, as well as, of course, MDs and DOs. And you can move on. Physician involvement. So after performing an examination, at least one doc, MD or DO, needs to determine that the individual, the person that wants to participate, is qualified. That can be either the prescribing provider, it can be a consulting provider, or it can be affirmation or attestation that the individual is enrolled in hospice. Why is that? Because by definition, if the person is enrolled in hospice, that means that they have been given and it's been attested to the fact that they have a 6-month life expectancy or less. And if the person isn't enrolled in hospice, then 2 providers must affirm that they have a 6-month prognosis. One may be a provider that's not a physician, but one must be an MD or a DO. And next slide. So question about capacity. What if a provider believes that this individual might lack decisional capacity, or that they have a current or recent history of mental illness that could impair their decision-making? One of our criteria is that the person must be decisionally capable. Well, the individual must be referred to a mental health professional. Medical aid in dying cannot proceed at this point until this person has an evaluation by a mental health professional. Now, this is all based, of course, on our, that our New Mexico law is the Universal or Uniform Healthcare Decisions Act. That act assumes that people are decisional, as we call it, decisionally capable. And it refers to those who are decisionally capable. If there is a question, as we're talking about here, the mental health professional that must be referred to here in our New Mexico law must be a psychiatrist, a psychologist, a psychiatric nurse practitioner or APRN, a clinical social worker licensed in our state, or an LPCC or licensed clinical counselor here in New Mexico. And they must make that determination before the process can proceed. Next slide. So the right to know, our law stipulates that healthcare providers need to inform the patient of all reasonable and legally available options for end-of-life care, of which medical aid in dying is one. And VSED, as Dr. Grube mentioned, is another. All of those that are reasonably available and are legal. And if a healthcare provider is not able or chooses not to participate, they still must inform the individual of their options and refer to another willing provider, or alternately, refer to an individual or an entity who will provide help for them to seek medical aid in dying. We know that no healthcare provider can be required or compelled to participate. So, no, when we talk about you can't be compelled to participate, you also can't be subject to criminal liability or sanctions on your license or any professional discipline for participating or for refusing to participate when a qualified patient is self-administering, participating in ingestion of the medical aid in dying medications. Further, a healthcare entity, provider, professional organization, an insurer, an MCO cannot discipline or censure or interfere with, for example, interfere with privileges or credentialing, membership in an MCO, privileges at a facility that cannot be interfered with for that provider participating or not participating in medical aid in dying. And then the next slide is, I think the next slide here, a healthcare entity that prohibits medical aid in dying on its own premises or by their employees shall provide appropriate public notice on their website and in relevant materials given to patients. So that would be on brochures or explanation of benefits or in admission materials where the services are listed and on the website. And a healthcare entity shan't forbid or otherwise sanction, and we've kind of talked about that, a provider who participates. This refers to someone who participates off premises, off hours, or outside the scope of employment. So if it is a hospice, let's say, or a facility who chooses not to participate in any way, and so their employees are not participating while they're on duty, they still cannot forbid those individuals, those employees from after hours or on a weekend or in the evening or when they're not on duty, acting on their own behalf, not on their employees' behalf. So no employee can be sanctioned for doing that outside their scope of employment. Just a definition of healthcare entity there to kind of clarify that. A healthcare entity is not an individual. It in fact is an entity like a hospital, a clinic, a hospice agency, home health agency, a pharmacy. We know that pharmacies are participating, a nursing home or similar group like that. And so I will now pass it, I think, back to Matt or to Dr. Grube next.
I'll go ahead and take that. Thank you so much, Ms. Hopkins, because that was very, very helpful, and outlines the elements of the act in New Mexico, and will make access better than it is in Oregon. Well, the experience of states that have authorized aid in dying is quite interesting. And in Oregon, for example, more than 90% of individuals that choose medical aid in dying are enrolled in hospice. It varies somewhere between 90 and 95%. Anecdotally, in New Mexico, I've been hearing, and of course we don't have this exact specific, but thus far, I believe essentially everyone who's considered using this and who has used it in the few months that it's been legal in New Mexico has been enrolled in hospice. Aid in dying is the epitome of patient self-determination. And that's, of course, at the center of our hospice philosophies. Hospices in New Mexico, as in Oregon and other states, may not really understand all the intricacies of the act, and therefore, and being involved in an individual who wants to consider this could be daunting for those. And it's certainly been the experience that we've had in our hospice here in Oregon. But there are very, very many safeguards built in the process. And if I may say, individuals who are enrolled in hospice and who are shown all the wonderful benefits that hospice and palliative care programs can provide, so often, after making a request about aid in dying, so often choose not to do that because they can then understand and learn about the wonderful things that hospice can do to improve their last days and to help them deal with their suffering. Next slide. So what we've seen in Oregon and what has been seen in the other states is that initially there was opposition in our hospice. We had a position, as did the Oregon Hospice Association, when initially our law was passed in 1997, to be opposed. But as patients requested this, and we had to figure out how not to abandon our patients, of course, one of the 4 tenets of medical ethics. Our hospice in Oregon and many other hospices, non-faith-based generally, moved to neutrality and studied neutrality. Studied neutrality essentially means that we will allow a client, a patient in our hospice to use this, but that's it. We're not going to do anything more than that, just accept that is an option that they want to consider. But then it became more clearly that more was needed and patients needed more help. And the process can be complicated, and sometimes a navigator, who is usually a social worker, could help them by providing literature, could provide information, can help them access providers, etc. So that then becomes an integrated neutrality. When the American Nurses Association removed their opposition about 3 years ago to aid in dying, then it became clear that the most important person who the dying individual wanted at the time of their ingestion was their hospice nurse. And so now in our hospice in Corvallis, Oregon, and in many hospices in Oregon and other authorized states, the nurse is present and can be with the patient at the time of ingestion. And subsequently, because these patients oftentimes, essentially their last months of care are essentially being provided by the hospice, we are now allowing the medical director of the hospice to either act as the attending or consulting physician. And this is true in other states and will be true in hospices in New Mexico. Next slide, please. So in order to help individuals and to help ourselves, we need to understand the statute, and that, of course, is what these series of programs have been for. Being prepared is so important because the response that we can give the patient is so much better. If we know where we stand and what the law is, we can be a better healthcare provider by either responding to the request or referring them to an appropriate alternative situation. Very important to understand their motivation, to ask why would they ask for this in a non-judgmental way, and then to assuage their fears and address those wishes that we can address in our hospice program. And as I mentioned, so often happens, individuals then may not even consider this after they've talked about it. But the important thing is that the conversation in and of itself is palliative. The conversation is palliative. We always need to affirm our commitment to support our patients. That's what it means to be a professional, to explore all of the options, which of course, as a good hospice provider that you do, to document their wishes, and at the very first time that they make the request, to make sure that it's documented in the chart. More important in Oregon than in New Mexico. Consider a navigator in your hospice or health facility, usually a licensed clinical social worker, but not always, who can help the individual go through the various steps that are required as they deal with this, because while they may have capacity, they also may have what I call mud brain, where there's so many things happening to them all at once that they and the family can have trouble making decisions. And since the pandemic has exploded and impacted all of our work, it is allowable for any of the steps in the law in New Mexico to employ telemedicine. Now, most of these patients are well known to us. They don't need to come back into the office for a conversation. We can do that through telemedicine. We've already been caring for them and examined them repeatedly. So most of these patients are known to us. And so telemedicine can save the dying person and their family a lot of difficulties by not requiring them to have to be present in person. Next slide. So how does a hospice participate? And as I mentioned, this is something that will evolve in your hospice. It's quite fluid. In our hospice, it's completely different than it was even 5 years ago or 10 years ago. But first of all, we need to listen and provide emotional support. We can, if we have an integrated neutrality in our hospice, we can coordinate with the pharmacist for the getting the prescriptions to help the family prepare a date of the patient's choosing, and we can be present and offer to be present. I did provide this option to several of my patients over the years, and I always offered to be present. As I mentioned, and I had been present in a few ingestions, but most often the patient wants the hospice nurse to be with them. So it is legal in New Mexico and other states to assist the individual by mixing medications, being present at ingestion, etc. But we can't administer. So there's a difference between assisting and administering. Assisting is legal, doing all the prep, etc. But the individual themselves must begin or complete the ingestion. And we should always remind them that at any time they can rescind their request. And again, it's their choice whether they're going to take it or not. And of course, after the individual has died, we could pronounce the death and notify the funeral home that this was a planned death, and so that there's no questions. Next slide. The medication that we're using now is a combination of medications, so it's needs to be compounded. So it's not, can't get it from a retail pharmacy anymore, as the historical short-acting barbiturates are no longer available. And as Ms. Hopkins stated, ingestion is allowed, but injection is not allowed. Ingestion includes swallowing through in a normal way, or through a nasogastric tube, or through a feeding tube directly into the stomach, or a rectal catheter, which is becoming more common because of individuals having a loss of, having some absorptive issues or vomiting or nausea. Next slide. The medication should be swallowed within 90 seconds or 120 seconds, it's about 4 ounces of medication, and that's quite a long time. But if it isn't, they'll fall asleep generally within 10 minutes, and so they need to get all the medication in. Generally, death will occur within an hour, but it can be up to a couple hours or even longer. And if we tell the family that the loved one is sleeping and they're not suffering anymore, that helps them understand and expect that it'll be unusual now. Average time to death is certainly less than an hour and a half. So we give 2 pre-op medications, ondansetron and metoclopramide, 1 hour before the combination of a gram of diazepam, 100 milligrams, not micrograms, of digoxin, 15 grams of morphine sulfate, 8 grams of amitriptyline, and 5 grams of phenobarbital. About 10% of individuals have a little burning afterwards, and so it's always good to have some soothing agent such as sorbet to be taken after the ingestion, which can soothe them and give them a pleasant taste in their mouth. Next slide. After death, the hospice pronounces death as would in any other situation. As Ms. Hopkins mentioned, On the death certificate, we write natural causes, and the terminal diagnosis of the hospice admission, etc. We do not write medical aid in dying. These are public documents, and it is in all states. This is what is done. Grief and bereavement services are important. And while aid in dying, the loved ones of individual who has used aid in dying may have a kind of a different type of grief. In my experience and in the experience of so many others, knowing that their loved one is no longer suffering is to be reminded of that is very helpful. If the medications are not taken, they should be disposed of along with other unused hospice medications, rescue packs, etc., in the usual fashion that your hospice would recommend. It's different in different hospices, it's different in different states, but the medicines that are not used, and fully 1/3 of individuals who have the medicine don't take it, should be disposed of, as are their other medications after their death. I'll talk about a case history or so, just to point out a few things about this. This was a patient in our hospice. I've changed some of these things, so he's not identifiable, but we'll say that it was a 92-year-old female who had very bad pancreatic cancer. She had been a painter her entire life, but had become blind from macular degeneration. And so that caused quite a bit of anhedonia. She was, however, very competent, had complete capacity. Her cancer had been approached in a number of different ways without success. And she ended up in an assisted living situation. And the assisted living had a supportive policy of allowing an individual to use aid in dying in their facility if that was their choice. She was in our hospice, and she requested aid in dying, and we had conversations with her about that, and with her daughter, who did not support her choice based on religious reasons. Although the mother was not religious, the daughter was very religious, and we had to have really some very hard conversations. And on the day of ingestion, the daughter was not present, and the individual asked if she could take the medication when our licensed clinical social worker and the chaplain were present. And the asked that they mix the medications for her so that she could take them, which was quite unusual situation because the licensed clinical social worker and the chaplain had not had that experience before. The nurse, in the rapidity of the ultimate decision, was not available, so that was done, and she had a very, very peaceful death. She fell asleep in a few minutes and died within about a half hour, very peacefully. However, it's very important, and on the next, we can move to the next slide, that when we have any of these kinds of situations, that we have a debriefing session. And so I think it was helpful and important for not only members of the whole hospice team, but particularly the members, the chaplain and the licensed clinical social worker, to talk about their feelings, their experience, what they might think. Ultimately, interestingly, in this case, the daughter, when she finally did return and was called to come back, was very supportive of her mother's choice, knowing that her mother was no longer suffering. So in our hospice, we do have, at least on every individual case of voluntary stopping eating and drinking, continuous palliative sedation, or medical aid in dying, we do have a debriefing session. And we have another, once a year, we have a full staff meeting to discuss all cases in the last year. And it's very helpful, not only to support one another, but to learn from these experiences. Next slide. So I'll go quickly over these next few slides so we can make sure you have time for questions. I already said this in Oregon, and you're going to find the same experience in New Mexico, that individuals who request aid in dying generally are in hospice and want to die at home. Some medical ethical questions. As you know, the American Academy of Hospice and Palliative Medicine has a neutral stance. The Academy has a medical aid in dying special interest group on their website, so where questions can be asked and information imparted and conversations are all available there. However, the National Hospice and Palliative Care Organization is still opposed. Next slide. Very important not to confuse our personal beliefs with our professional integrity. As I mentioned earlier, to be a professional means to put the patient first. So I think it's really important to examine our own personal beliefs and make sure that they're not interfering in our response to the patient's request. If medical aid in dying is something that we are opposed to individually, that's fine. And as Ms. Hopkins mentioned, no one is obliged to support the patient's choice. But it's very important to let the patient know that we are understanding what their request is, and that we would then refer them to another provider to discuss their end-of-life options. We don't refer for medical aid in dying, we refer to discuss end-of-life options. Next slide. And it aligns, medical aid in dying aligns with the 4 pillars of medical ethics, in my opinion. Certainly with the patient autonomy, their choice, and their right to choose. Doing no harm. If we remember that harm is defined by the patient, they are the ones who are suffering, and we need to listen to them. It's not whether we think they're having harm, but it's what they think. And beneficence, same thing. And then finally, non-abandonment or fidelity. Next slide. Their studies have shown, and here's an example of one in the Journal of Palliative Medicine, that having complete conversation about end-of-life options has a positive impact on palliative care and thus hospice programs. Next slide. And I would tell you that I believe that there's absolutely a positive impact on the clinician-patient relationship. Now, the American College of Physicians says that aid in dying erodes the doctor-patient relationship. In my opinion, that is not the experience that I had. When my patients can trust me to give them all the information that is out there and have them choose, that engenders trust. Next slide. Okay, I'll finish up. As I said before, aid in dying is not a failure of palliative care or hospice care. Having the conversation is palliative in and of itself, so important to know that. Medical aid in dying is person-centered. Language does matter, and professional integrity is paramount in this arena. Next slide. So at this point in time, I'll be available for questions, and I think Matt wants to mention a couple other things before we get into the question area.
Sure thing. Well, thank you everyone for being with us so far, and thank you to Dr. Grube and to Libby for your wonderful presentations on this. Also want to highlight there's some upcoming trainings coming forward. We're going to be having another webinar on November 17th. This one will be on pharmacology and clinical competencies in medical aid in dying. We'll be joined by Susan Guest, who is a pharmacist in California and runs the pharmacy portion of the End of Life Option Act program at Kaiser in Southern California, so has a wealth of experience. So we're very glad to have her on board. Also want to draw people's attention to the City of Hope End of Life Symposium. This is going on in Las Vegas, but it's also happening virtually, and it's a 3-day opportunity to dive into all sorts of issues, from issues related to medical aid in dying, to integration of palliative care and emergency room conversations, to equity at the end of life and how to address concerns there. So that information is available on the Compassion and Choices website, as well as the City of Hope website, to again register and attend either in person or virtually for that. And there's quite a bit of continuing medical education credit available for that. And then finally, if you missed our last webinar that we did for New Mexico on September 22nd, recording is available at the End of Life Options New Mexico website, which, speaking of which, is a new resource which is available in New Mexico to help people who are weighing all of their end of life options. Libby, I don't know if you want to talk in more detail quickly about EOLO New Mexico.
Sure. One thing that's important for you to know is that we do have a hotline, and that's staffed all the time. So I noticed in the Q&A, several people were asking, how do we find a provider who prescribes? How do we find a hospice? Those kinds of things. And in addition to as you saw in the chat, of course, Compassion and Choices has a find a provider service. We at End of Life Options New Mexico also do, and I think Jill put our number in the chat. We have a newsletter, and you're welcome to sign up for the newsletter. I would love if you would do that, and it's a great source of information, and you can go back to past newsletters. Jill is probably on, and you can put in the chat. Did I miss, or Barrick, anything about End of Life Options New Mexico? We're a nonprofit, and I'm trying to look to see if anybody else wanted to comment further, or if you guys wanted to comment further on our, we also have volunteers that will sit at the bedside. It's interesting that not as many people, as Dr. Grube said, well over 90%, I think more than 95% of people nationally, and certainly here in New Mexico so far, have been enrolled in hospice. And so either staff from their hospice, the provider that wrote the prescription from their hospice, or the outside provider that has written the prescription has been present. So we haven't had that many people so far that have required that, but we do have trained volunteers that will be present at the bedside, will help the family mix and those kinds of things. And calling us or emailing us will get you to those people.
Wonderful. Thank you. Thank you. Just to point you to some other resources as well. Obviously, here's the EOLO New Mexico site, Compassion Choices site, as well as Death with Dignity National Center site, and the American Clinicians Academy on Medical Aid in Dying, which is another organization focused specifically on some of the clinical pieces around aid in dying.
And Matt Acamade, or American Clinicians Academy on Medical Aid in Dying, I saw that there are a lot of nurses, and being a nurse, they have for all providers a lot of very specific information. They have a listserv that goes on continuously with questions and discussions, but they have the most fabulous set of videos for nursing and how they might participate, as well, of course, as the providers. It's a great resource.
Wonderful. Well, I want to make sure that we have time. We have a lot of questions. We have about 11 minutes, so I'm going to see if I can lightning round them as much as possible. The first being quite a few questions around the IDT and experience or cases, Dr. Grube, that you could share about how it works when there are different members of the interdisciplinary team who have differing views on medical aid in dying, and how those pieces are resolved or worked through.
Well, yes, of course, it's very, very important inside the hospice to have these conversations and not to wait until you have an individual already enrolled in your hospice who wants to consider this option. So having conversations beforehand are so important. Allowing team members who do not want to participate to have the freedom not to, and have an understanding that there will be a number of individuals who aren't sure. And as it goes through, they may change their mind. So the only way to do that is to have continuous conversations in the staff and have trainings. And every single case is different. It's just about the time that you think you figured out how to manage these cases, something else will happen. But that's the nature of our work. And by caring for one another and being professional, answers can work.
Wonderful. Well, speaking of the kind of ongoing conversation, there's also some questions around the decisions that go into kind of setting a date for when a person decides to take medication, and whether or not that's something that has to be done, or whether that could be a flexible piece. How is it that medications are tracked? How is it that the IDT, the nurse case manager, interacts with the person as they're going through this process? I wonder if you could, either one of you, share a little bit about that, about how it is that that conversation happens. Does a person have to put a date on paper? How is it that that goes about?
No, they don't. There's no need for putting a date on paper. And of course, as I mentioned, fully a third of people who have the medicine and say they're going to take it don't. And that's year after year after year, 1/3 of people. But by being empowered to have that, again, having conversations ahead of time is palliative and helpful. On the palette of palliative care, we talk about things like thinking about your last day. Do you want your family there? Are there people you don't want there? Do you want music? Do you want your chaplain? Do you on and on. And then a simple question added on is, do you want to determine the day? And if you want to pick a day, we'll support you. Most people don't pick a day, but it happens because their suffering gets so bad that they finally say, I've had it now. And in most cases, that's been going on for quite a while, and it's not a surprise for the team, for the hospice team, any of the providers or the family.
Wonderful. And there's also some questions about administration, self-administration. So, and Dr. Grube, you clarified kind of what the various routes of that might be, but again, some specific questions around things like ALS or other neurodegenerative disorders. How is it that a person self-administers in those scenarios? What is it that a hospice team or a caregiver would be able to provide up to the point of administration to make that possible for those folks?
The individual who is dying and requesting this must initiate and or be able to not stop the ingestion at any time. So that can be very complicated in an ALS patient, for example. But there are many methods, and as Ms. Hopkins outlined, there's conversations that you can have through ECHOMAID, but also through the American Academy of Family Physicians website, and also the American Academy of Hospice and Palliative Medicine website. For example, if an individual can't use their arms, it's allowable for anyone, the nurse, the doctor, the family member, to hold the cup, and the individual can suck the medicine out on a straw. So the person holding the cup is not administering, the individual is instituting sucking and or stopping sucking. A rectal catheter can be inserted by the hospice team for use for any of the rescue medications. But at the time of ingestion, the individual must be able to push the plunger on the syringe to get the medicine in. And there can be creative ways that can be done if an individual has difficulty with power in their extremities, etc. So each case is a little different, and mentoring and talking with other healthcare individuals can be helpful.
So I did see somebody asking about somebody with advanced dementia and how they may participate. And unfortunately, the answer is that they cannot participate because they aren't considered decisionally capable. And the person must be fully cognizant of what they're doing, what the consequences are, and that is So that's not somebody who's going to be able to participate in that. And just in addition, this is also something that cannot be put in your advance directives. Everything else, I mean, I have in my advance directive, please use palliative sedation if need be, if my symptoms can't be managed. And they follow that if, but you cannot say this in advance in your advance directive, because you don't know what your mental status will be and whether you will be qualified at that moment. And the other thing I wanted to comment on is sometimes if you can't figure out how somebody who, for example, is a quadriplegic can push that plunger for the a Macy tube, a rectal tube, or how they get, sometimes an OT will be able to help figure out how with a foot or another way they can self-administer.
Yes, thank you very, very much. I think also we want to be reminded that an individual, as they're going through the process, may lose capacity. For example, if they have brain mets, they may start out making the request, etc., but by the time it gets to the writing the prescription, they may have lost capacity. So we have to be aware of those things. And that's, again, the wonder and the benefit of being enrolled in hospice, because those assessments are ongoing. And if the person's not in hospice, a lot of change can happen over a period of a couple of weeks that we aren't aware of.
Well, and Dr. Grube, you just alluded to, if the person is not on hospice, there was a question that came into the chat about, what about the case of a patient who is refusing hospice, is not wanting family present at the time of ingestion, is really wanting to do this as a solo act? Any advice, for that kind of situation where, again, you don't have the benefit of the hospice team around the person, but still want to support that patient?
Yes, we just need to then explore why they would have those opinions. It is always recommended that is never recommended that someone do this alone. It's always recommended that they have someone with them. Now, sometimes it's not possible to have the family there, or they don't want the family there. We need to explore what that is all about and find out if there's something that we can do to work out the situation. And it is not required that people be in hospice. But I do have to say, a good clinician helping a person understand the benefits of hospice pretty much in almost all cases should be able to get them enrolled. It's not a requirement, but every case that I dealt with, I made sure they were in hospice. And I have to say, really, in my experience, it was beneficial for them.
And in that case that was brought up in the chat, if the person were on hospice and wanted to be alone, hospices participate in many ways. Maybe they would agree to having the social worker or the nurse be outside and not with them, or something like that. And then they wouldn't be completely alone, but they'd have this sort of feeling of being in their rooms by themselves and still have some support and know when their death occurred.
Great answers. I'm going to end with this question, which is kind of a two-part one around healthcare entities and healthcare facilities. And so one part of the question being, is this something that people can do in a residential care setting, be that a nursing home or adult foster home or wherever it is that a person has been living? And how is it that, this interplays with policies there? And then when it comes to the advance notice part, the part that healthcare systems and hospices need to provide notice of the fact that they are not participating, for example, what does that look like typically? And what would be a good kind of best practice for that? Pose those questions to both of you.
Well, I'll let Dr. Grube go ahead because they're further along, much further along in being able to do that in facilities in Oregon, and we're not quite there.
Yeah, so of course, this can be done in an assisted living or nursing home situation. Interestingly, most people, of course, die at home, as I mentioned, and oftentimes for ingestion, a person is taken home out of the nursing home just for that day, because that's what they want to be. They want to be with their family. They want to be with their dog. They want to be in their situation. What the policy would look like, of course, would be dependent upon the corporate structure that writes their policy. So it could be anything. Fortunately, you have this in your act in New Mexico. We don't actually have it in Oregon, where a healthcare facility must write what their policy is and make it public. I wish we had that in Oregon. We don't, but the policies are written in different ways, so it's up to the institution.
Wonderful. Well, that takes us to the end of the hour, and it was a jam-packed one with a lot of information, a lot of great questions. And I appreciate all the questions, because that's where we really learn where it is that folks are working, and the fact that you're sharing those with us allows us to further tailor this education and to make sure that we're answering those questions in subsequent offerings. So if we didn't get to your question, hopefully some of them were answered in the course of the presentation, but we'll also make sure we keep a log of those so we can follow up on ones that need to be followed up on. So that you know, today's presentation was recorded and will be available. And normally we put them up in a matter of days. Again, by the end of the week, you'll be receiving all of your certificates for continuing education. And I think that's it for the housekeeping side of things. So I want to close with gratitude for our presenters today for sharing what they did, and for all of your help in helping us understand this issue of how it is that hospice is involved in this new option in New Mexico. And I want to thank all of you for taking time to engage with this, because it suggests that you're wanting to make sure that you're supporting people in the best way possible. And what more could we ask for from those of us who are caring for our loved ones, the people in our families. And so I just want to thank you on behalf of Compassionate Choices and End of Life Options New Mexico for taking the time today, and even more so for your commitment to those that you care for. Thank you so much. You're welcome.
One more thing is just to remind everybody that if you do want a presentation at your IDT, IDG, either virtually or in person, or small group training, just give a call or an email to EOL on New Mexico, and we're happy to do that for you.